no, I'm not an expert on PowerPoint either. So I'm going to talk to you about pain management, and sadly, as you, I feel a bit in the lion's den because I know that at times it's far from perfect. But perhaps I'm going to explain to you a bit why that is. So we're here in our lovely new blue building, and the outline of what I'm going to talk about today is what pain is in terms of what us as doctors feel about it, how we can treat it, the place of drugs in chronic pain, whether the success of them, and maybe some other options to think about. And when I was thinking about this talk, I thought, what do people ask me all the time, patients? And obviously people wonder why they have pain. They certainly wonder about the treatment. They wonder what they can take, whether things are dangerous or safe. They wonder why drugs don't help so much as they would like, and wonder about if they can do anything else to help themselves. So hopefully during the course of the next, only I hope 10-15 minutes, I'll address some of these and then obviously be able to answer questions later on. So pain is a complicated thing. It's not a simple sense. It's not like being able to hear or touch. And because it's complicated, we have a complicated definition, which is pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And the important words there, I think, are unpleasant. Pain is always a negative experience. It's always associated with an emotional response in real life, but it can be associated with ongoing tissue damage and sometimes not. So it doesn't always mean that things are that you've got bad things happening in the body. So sometimes it seems to just sustain itself. We've known for years and years that what happened in the periphery, this is a fire at the bottom of Descartes' drawing in the 15th century, that somehow the message of the pain of that fire got up to the brain. And as you can see here, there's a very simple line from the toe into this young boy's brain. It's a bit more complicated than that, which I guess you won't be surprised to know. But essentially, there are three places where pain gets generated, and it starts often in the periphery. Now this diagram has a hand, but it could be the gut. It then passes via nerves up to our spinal cord, and then further up into the brain. Now the good thing about this is that at every area there are areas where we can target pain, both with drugs, and there are also areas where nerves join other nerves, which gives us the opportunity to change that message and therefore that experience of pain, either with drugs or maybe with other things. Now in the brain we know quite a lot about the spinal cord, we know much less about the brain, but we do know that the bits of the brain which are active when you have chronic pain, which is long-standing pain, are quite closely associated with some of the other bits of the brain which control things like appetite and mood and feeling sick, and so they explain why pain has other effects on the sufferer. And that's why pain is nearly always associated with other symptoms. So you don't just say, I've got pain, you actually then describe all other bad effects. Top of the league, as you can see from here, is not being able to sleep. Always a bad start, not being able to sleep, people lose the day-night rhythm. So all of those things can make things worse. People feel tired, they can feel drowsy, can't concentrate. And we know, unfortunately, that there's a very high incidence of depression and anxiety in patients who've got long-standing pain. So uniquely, pain, as I say, is not a simple sensory thing. It is certainly associated with things happening to your peripheral organs, but it also has big psychological impact. Similarly, how you feel will affect your pain, and also we know, actually looking at big studies, that whether you're happy in your job or enjoying school or everything like that will also affect your pain experience. So it's complicated, and therefore perhaps it's not so surprising that it's not like giving an antibiotic for an infection. It is different. Just to say that what I'm going to be talking about really is chronic pain. Acute pain is what we call pain which lasts for a short time and will, by definition, go away. It's the sort of pain we see in hospital when people have had operations, or pain you might get when you break your leg. Drugs actually are very good for acute pain. They tend to work well, And of course, side effects, if you're in hospital having had your appendix out, then if you're a bit drowsy, it doesn't really matter. But obviously, if we're then talking about longer term, then the side effects of drugs get much more important. So chronic pain, by definition, long-lasting. Drugs aren't so effective. Adverse effects are much more important, in fact can be worse than actually the benefit of the drug itself. So our challenge is that we need a long-term strategy, not something that we're going to do for 2 or 3 days after an operation, say. We know that because of this complexity, that the drugs don't work, and I have to tell you the depressing news that if we are assessing a drug for its efficacy, how well it works in pain, then in scientific journals, in our studies when drugs are coming onto the market, we look for a 50% reduction in pain. So we don't look for no pain, because we know that's probably not going to be achievable. Having said that, we do know from lots of studies that 50% is significant in terms of all of us as patients and people, that dropping your pain by 50% will actually be beneficial to you. We know that psychosocial factors are common, as I say, mood can be low. So because of that, actually in the chronic pain world, and actually I'm an adult pain practitioner, so we use actually lots of different techniques, and pharmacology, which I'm going to concentrate on most of this afternoon, is only one of them. We know that even in all sorts of pain, that people tend to be better if they're more active, that if the exercise is good for both pain management and mood, and the corollary of that is that rest is not very good for us as human beings. The body, certainly its musculoskeletal side, is designed to move, and one of the problems that conditions like this have is prolonged admissions in hospital can actually lead to other things like back pain and stiff joints and things. So this can compound the problem. So keeping active is important, and certainly in pain management program settings there will always be physiotherapists involved. We're believers in alternative treatments, although we don't have all of these within our services, and we also work whenever we can with psychologists because of this very close relationship between pain and how you feel. And this is a positive thing. This is not saying people have got pain in their head, but the brain is so powerful that actually you can use psychological techniques to help your pain. So it's more about helping the messages shutting off your pain from your brain rather than saying this is any kind of mental illness. So what about pharmacology then? Well, we all know about painkillers because we all experience pain and everybody's taking paracetamol and ibuprofen and things for headaches, and indeed they are effective in these acute conditions. So if we look at the group that we have in what I would call conventional painkillers, we do indeed have paracetamol, the anti-inflammatories, which are the non-steroidals, and then the opioid group, which is basically morphine, which is anywhere, in fact, from codeine up to morphine. But then we also use, and I expect some of you have had experience of these, we use more unconventional things which we sort of borrowed from other parts of medicine, which can be some of the anti-epileptic drugs and the antidepressants. So I'm just going to talk a bit about these now. So one of the things that happens particularly in hospital is that we tend to use the WHO pain relief ladder. Now this was actually designed for two reasons. One, it came out of the palliative care movement because there was a lot of worries about using opioids, and this was actually back in the 1950s. It also, the WHO side of it is because even now in many parts of the world morphine is still actually very difficult to get. It's not freely available. But essentially it divided our strength of painkillers into 3 steps, which are the non-opioids, which essentially are our paracetamol and anti-inflammatories, weak opioids and the strong opioids. Paracetamol, if you're in hospital, I suspect you'll find you have paracetamol always. We give virtually everyone who comes into hospital paracetamol. It's in a class of its own. It's uniquely well tolerated, usually. It can be used in conjunction with other painkillers, and except in excessive use, it is extremely safe. So that tends to be a baseline, but of course, as you will also tell me, and I would agree with you, that it's often not effective, or certainly not effective enough. The anti-inflammatories we again use in acute pain. I would probably make a case that it's unlikely, they're not very helpful in chronic pain. they are particularly targeted against the sort of inflammatory changes that you get with acute inflammation, such as infection or trauma or surgery, for example. But in long-term cases, the inflammatory side of things tends to be fairly unimportant, and there are lots of reasons, probably in the long term, particularly people who've already got problems, not to use non-steroidals. So up to the weak opioids, and you'll all know how many combinations there are of paracetamol and codeine, several on the market with varying degrees of codeine in them. Codeine turns into morphine in the body. So although we talk about step 2 and step 3, if you take enough codeine, you will actually be already on step 3. You will be having quite a lot. But of course, we also know that codeine is particularly bad on the constipation side, so it's something I'm sure that we possibly try and avoid. We do use drugs like tramadol, which is again a step 2, and then beyond that we move up to what we call our opioid or morphine strength painkillers. Now these have advantages that they are the strongest, there's no doubt. They are gold standard. As I say, particularly if you've broken your leg and come into casualty, then the morphine will help you a great deal. The other advantage is that we now don't always have to give it by mouth, which obviously can be problematic, and someone's already mentioned a patch actually, which we can talk about in a moment. There are disadvantages. The same disadvantages, unfortunately, across the board, is that they don't always help as much as we would like. They often don't help as much as we would like. They can have effect on sedation, making you a bit drowsy. That can have an effect on memory and cognitive function, which in the longer term is something that you definitely don't want to have. Nausea and vomiting is usually self-limiting, so most people, from just getting nausea and vomiting from using morphine, it will settle down. But unfortunately, constipation doesn't. The one thing the body doesn't get used to in terms of using long-term opioids is in the gut, and constipation is a constant problem. And of course, on top of difficulties already, this is where opioids have to be discussed in terms of their pros and cons. These are the names of them. I'm sure you've probably all seen them, so a lot of you have been on them, but I can't answer individual questions about patients, but obviously about individual drugs I'll be more than happy to ask questions at the end. So we know they're effective, although not always, and not completely in chronic pain. We know they've got a fair amount of side effects, and this is true for all of our, and because of their concerns about long-term use, there are some guidelines for their use in chronic pain, and probably one of the most useful ones is this one from the British Pain Society. You'll see here that in an ideal world we like to think that we won't give people more than 120 milligrams a day. We don't live in an ideal world, so clearly that's not always going to be always going to be the case. But there are implications for some of the practicalities of life, particularly things like driving, being on a high dose. There's also another problem with high dose of morphine, is that sometimes the good effect actually becomes reversed, and in fact you get what we call in the jargon opioid hyperalgesia. So somehow your receptors first of all stop responding, but even putting the dose up then won't be helpful. So this is another reason that we try and avoid escalating into high doses. So what about the other drugs? Well, as I've already said, we tend to borrow these from other specialties, if you like, and the two ones we use most are antidepressants and anticonvulsants. Now, I'd like to emphasise again that antidepressants are not given because you're depressed, they're given for pain. Not all antidepressants do help pain, in fact. So there may be we may well use a combination. You may be on something for depression, but you might use another sort of antidepressant to help pain. In terms of the evidence, they've got good evidence that they can help, and one of the side effects they may have taking them at night is to help you sleep. So even if the pain is not a lot better, getting better sleep can be overall beneficial. Fortunately, these also come with side effects. Constipation again, sadly. Again, also drowsiness, and a dreaded dry mouth actually is particularly problematic with these. And we've actually, the newer ones called Duloxetine and venlafaxine are probably slightly better tolerated than the older ones. They're the same group, but like with many new medications, they're new and they're better, not so much because they're more effective, but because they actually have less side effects. And again, we can use those to help some of the bad effects of pain, like not sleeping. So the ones that help, therefore, are the amitriptyline, nortriptyline, duloxetine, and venlafaxine. The ones that don't help are actually, in some ways, our best and most modern antidepressants, which are the ones which only affect the serotonin, which is one of the chemicals in the brain. But actually, that doesn't seem to have much effect on pain. So fluoxetine, which is Prozac, citalopram, and sertraline. What about the anticonvulsants? Now, antiepileptics, it might seem a bit weird, but one of the things that happens with chronic pain and those changes I mentioned in the spinal cord and in the brain is that everything's a bit sensitive. Sometimes people find that even though they've got a chronic pain which is in their abdomen, they're actually quite sensitive in the rest of their body as well. And the whole of the nervous system seems to be overexcited, if you like. And of course, if you have an overexcited bit of brain, you may have epilepsy. So this is a reason that these are similar, that these drugs may be useful in chronic pain. The best two, which are quite similar in terms of their molecular structure, are gabapentin and pregabalin. They are both licensed for chronic pain, and pregabalin also actually has a license for anxiety, which of course can be a big confounding problem with chronic pain problems. Sadly, again, side effects are important here. Probably the biggest is sedation and not feeling yourself. They are quite mind-altering, and they can make people feel quite low in mood, actually, which needs to be watched, certainly when you start medication. They also occasionally cause weight gain, which can be problematic. So what we sometimes do, in fact we quite often do, is combine medication. Now I don't know, some of the older people among us might have problems with blood pressure, and you'll know that your doctor often gives you 2 or 3 drugs for blood pressure now, not just one. And that's a sort of thing that is mirrored across medicine. And the reason to do that is to try and get your maximum effect with your minimum side effects from a particular group. And if we go back to my body, you can see that my schematic body, you can see that lots of the drugs I've described work in different ways. So it's quite a reasonable thing to say, well, let's have a bit of this and a bit of that, and particularly perhaps we'll be able to drop your morphine dose because we'll give you something else. We'll get you sleeping better, and that may help as well, all of these things. So combination of medication is important, although I think we also have to be careful, as we do in all chronic problems, is over-medication. So there's no point in us just giving you so much medication you're not awake. That's obviously not useful. So in summary, the drugs have an effect, they offer some relief, but the cons are side effects. And I suppose that brings me on to how we judge success. We all want to have our patients to have less pain, but given that that may not be ultimately being driven to zero, what we also want to look at is quality of life. Are you actually doing more, doing things you like doing? Are you sleeping better? And are you not troubled by lots of side effects? So it's quite a complicated equation, and I think one of the things that particularly if you try a new medication, is to think to yourself, is this drug helping at all? So if it's helping, but perhaps not enough, that might be a dose problem. But there are occasions where you're given a sort of drug and actually it won't help at all. It doesn't matter how high we put the dose up, it won't suit you. And so if you're a responder, the benefit is on your blue side. You may have benefits not just in pain but in sleep. Because of that you may feel less tired, you may feel better in mood, and overall your quality of life is better. And so that your balance, looking against possible side effects, is all in a positive way. So it's worth continuing this medication. What you don't want to do is find yourself in this situation where actually, if you think about it carefully, the medication hasn't really helped, and in fact you've got some side effects. So it's not an easy balance, but it's something that you need to bear in mind, as I say, particularly when starting new things. So are drugs the answer to chronic pain? Sadly, the answer, I think, to that is not completely. They're not as efficacious as we would like. I've discussed which drugs we use but my final message, I suppose, is individual variation. I've given you a discussion of what we can do. There is some evidence, which obviously it's all pooled information from lots and lots of patients, that these drugs are effective, but that doesn't necessarily help me treat a patient sitting on the other side in the consulting room. All patients are individual in whatever field of medicine. I think that's never more true than in chronic pain. where we know that people just react differently to different types of drugs, and it may be that you have to work through those to see what particular combination is for you. So whatever we say doesn't mean that we it's never do never, because we all live in the real world and we all have our individual patients. But we do want to be careful that we're not just giving people side effects without much benefit. So in summary, of course, we treat pain. We do, particularly in adult, look towards trying to help some self-management. We do look at our outcomes in terms of activity and quality of life, and we obviously know that there are other things that can help, psychology, and of course things like this, group support, is so important in particularly rare conditions, and of course this is one way where the internet has really come into its own. And that's all I'm going to say. Yeah, thank you.